Can a simple Doppler save your baby's life? Yet, do you know, a simple umbilical artery Doppler is one of the most critical tests to save a baby's life, and yet it is most misunderstood and it is not done in most of the pregnancies. Hello, I am Dr. Rajat, and today I will dissect umbilical artery Doppler for you in a very simple manner. It will become easy for you to understand when umbilical artery Doppler is done, why umbilical artery Doppler is done, how to interpret the results of umbilical artery Doppler. By the end of this video, you will understand when and how to read your ultrasound Doppler reports. Please watch the video till end. There is a bonus tip as to when you should report to a doctor or when your doctor should take a critical call of delivering your baby out. Hello, I am Dr. Rajat, and you have started watching our YouTube channel, the Fertility Gynecologist. In previous two videos, I have discussed about NST and uterine artery Doppler as a measure of fetal well-being. It is a part of antepartum fetal surveillance. In today's video, we will discuss about the umbilical artery Doppler and various changes and the progression, how the Doppler worsening occurs, and at what critical point do we need to take the baby out so that we save the baby. Now, I've discussed before that this is the uterine artery. It supplies the uterus. From uterus, it is supplied to the placenta. From placenta, it supplies to the umbilical cord, and there in umbilical cord there is umbilical arteries and umbilical vein. There are two umbilical arteries and one umbilical vein, and which supplies the fetal act. We discussed the uterine artery Doppler. The moment there is a problem in the uterine artery Doppler, they manifest later on in the umbilical artery Doppler. The progression of Doppler abnormalities for fetal growth restriction due to hypoxia, they play out in a very well orchestrated and a sequential manner. Initially, because of the placental resistance, there is a cerebral vasodilatation, followed by the cardiac dysfunction, followed by the venous changes, and then ultimately leading to a fetal compromise. Initially, the uterine artery resistance increases. It is manifested by the increase in RI and PI, followed by the umbilical artery resistance, which is manifested as increase in PI, RI, and that may manifest as absent or a reversal of an end diastolic flow, that is called as AEDF or REDF. After that, there is a brain sparing effect. The critical placental resistance leads to a brain sparing effect. That means the critical organs like brain, heart, and adrenals, they get more supply, which is manifested by decrease in PI of middle cerebral artery. After that, there is a cerebro-placental ratio which becomes less than 1, and that is the time when the critical cardiac and peripheral arterial changes occurs. After that, the aortic stomach PI increases, which means that there is an increase in the reversal of flow, followed by the cardiac changes. These cardiac changes, they indicate that there is an increase in the right and the left ventricular diastolic indices, decreased cardiac output, followed by ductus venosus changes, the increased pulsatility and the loss of A wave. And lastly, there is an umbilical arterial pulsations. There is reversal of A wave and then severe cardiac dysfunction followed by fetal death. So in early cardiac changes, that is in the arterial redistribution, the first sign of a fetal hypoxia is usually a rising umbilical artery PI, followed by the moment the umbilical artery PI rises, the placenta, in order to, there is an increase in placental resistance. So in order to get the more oxygen and the nourishment to the fetus, there occurs a cerebral vasodilatation, and that is manifested in the Doppler changes by a decrease in middle cerebral artery PI. These are the early changes. These arterial changes occur in the early half of the hypoxia. Intermediate changes are cardiac changes. As the hypoxia progresses, the fetal heart begins to fail. I'll come to it in bit detail in the later half of the video. This is observed as in the Dopplers as the rising pressures of the aorta and dysfunction of right ventricle, often manifested as tricuspid regurgitation. And the late changes are always venous changes. The ductus venosus, the vessels which allows the oxygenated blood, it bypasses the liver and it becomes highly pulsatile, indicating that ventricular compliance is severely reduced, and the pulsatility in ductus venosus, it indicates, umbilical vein indicates severe right heart failure. And the progression of from an early arterial to the venous changes takes about 1 to 2 weeks. So this was the summary. Now I'll go into the detail. Umbilical artery is an indication of a fetal well-being. Umbilical artery Doppler is a marker of placental insufficiency, and it is a consequence of severe fetal growth restriction or severe preeclampsia. Earlier, we used to do umbilical artery Doppler in high-risk cases, in maternal high-risk cases like hypertension, diabetes mellitus, IVF conceived pregnancies, chronic kidney disease. or for fetal disorders like fetal growth restrictions or twins, oligohydramnios. But nowadays we have made it a rule to do a umbilical artery Doppler for every pregnancy. We start umbilical artery Doppler, start at about 28-30 weeks, again repeat at 30 to 34 weeks, and then depending upon the results, we repeat it. Umbilical artery Doppler, if you see on the graph, is a classical sawtooth appearance followed by a continuous venous forward flow. The resistance towards the placental side is low and resistance towards the fetal side is more. Normally, whenever we do an umbilical artery Doppler, we always do the Doppler towards the placental side, but sometimes it is very difficult, so we take it at three places: fetal side, placental side, and the free loop, and then we take the average of these values. Normally, umbilical artery values are manifested as SD ratio, systolic diastolic ratio, RI and PI, but for our practical purposes, nowadays we don't use SD anymore. We mainly use the umbilical artery PI as the main value. The mean value of umbilical artery PI, it decreases from 1.2 to 0.967 as the pregnancy grows, as the maternal vascular system grows, as more and more villus vascular system grows under transformation, and more than 50% of the stroma transforms into the vascularized. The umbilical artery PI decreases throughout the pregnancy. So with increase in gestation, the umbilical artery PI in a normal pregnancy should decrease, and that is because the more and more vascularization, the villi are going more and more into the uterus. Descending aorta, the fetal descending aorta is a very important landmark as far as the fetal Doppler is concerned. And after 34 weeks, rather than the umbilical artery, it is the descending aorta which is important for measuring the various changes. Whether the delivery should be delayed or delivery should be continued, it is a very, very important thing. Whether the baby should be, there is a risk of a prolonged exposure to the fetal hypoxia, hostile intrauterine environment. But the trick is, if there is an early FGR, a chronically starved fetus who is having an early FGR will better tolerate the intrauterine hostile environment for a bit longer compared to the late FGR, in which till the end there was a good intrauterine environment and suddenly the blood supply decreases. That fetus may not be able to tolerate. The reports have suggested that in fetuses in whom there is an aortic isthmus increase in resistance, they might have some kind of an neurological dysfunction later on in the life. However, in early brain sparing effect, the studies have mentioned that if there is an early brain sparing effect, those children have been followed till 5 to 7 years. They do not have a documented neurological dysfunction in those things. This is a dynamic process. Like I mentioned, with placental resistance, there would be an arterial redistribution first. The main purpose of this arterial redistribution is to supply more blood to the brain, more blood to the heart, and more blood to the adrenals. And there would be less blood to peripheries, less blood to the kidneys, and less blood to the other organs. When the reserve capacities of the circulatory redistribution reach their limits, that is when the fetal deterioration starts and an iatrogenic delivery should be considered. So like I mentioned before, the first sign is increase in the resistance of an umbilical artery PI. Increased resistance in the umbilical artery PI does not directly mean that we have to deliver the baby. We still have about 2 weeks, 1 to 2 weeks more to do anything. It is the increase in umbilical artery PI is followed by an arterial redistribution. This arterial redistribution is manifested by increase in cerebral blood flow, decrease in the cerebral artery PI, middle cerebral artery PI, and that is called as a brain sparing effect. When this brain sparing effect, so in the first stage of arterial redistribution, the shift becomes to the left side of the fetus and there is a more of the blood supply, left ventricle output becomes more to improve the cerebral perfusion. But with deterioration in the fetal condition, the cardiac output decreases and that leads to the progressive decrease in the cardiac function. That is the middle phase of redistribution. But it takes 2 weeks from arterial redistribution and towards the fetal distress. As long as normal venous flow is there, that means fetus is compensated. This is a carry home message from this video. Middle cerebral artery in brain sparing effect does not mean that you have to deliver the baby. As long as there is a normal venous blood flow, the details I'll come to it later in the video, the fetus is being compensated and we do not need to deliver the baby. We can still wait. However, abnormal venous blood flow indicates the breakdown of the hemodynamic compensatory mechanisms. Lastly, there is an abrupt increase in the pulsatility of ductus venous waveforms with loss of forward flow. during the atrial contraction, and this indicates the pathological fetal heart rate pattern. These hemodynamic changes which occur in the fetal arterial vessels during hypoxemia and acidemia are induced by the uteroplacental deficiency, and they occur in a particular order. After umbilical artery, there is a descending aorta resistance which increases, followed by a renal artery resistance which increases, followed by an increase in femoral artery resistance, followed by an increase in the peripheral pulmonary artery, increase in the mesenteric artery. These increased resistances are very important, which I'll come to it later on in the video while deciding, because the more we wait, the more resistance increases to the same mesenteric artery, the more chances of necrotizing enterocolitis in the baby may be there. Followed by the increase in the cerebral arteries, then decrease in the adrenal arteries, then decrease in the splenic arteries. The moment there is an increase cerebral artery PI, decrease in the adrenal and decrease in the cardiac coronary blood flow, that means the end is near. There would be a pathological fetal distress and the baby would be acidemic by then. Important point to remember is after 34 weeks, cerebro-placental ratio should not be taken as an indicator of a fetal well-being. Rather than the cerebro-placental ratio, it should be the ratio of middle cerebral artery PI and the descending aorta PI. Now this fetal cardiac Doppler is very, very important. Once when the earlier arterial redistribution changes have occurred, then the middle phase of the fetal redistribution, it happens in the fetal heart. Doppler cardiac flow is greatly influenced by the modification of the arterial impedance, as I have told. This leads to a cerebral vasodilatation. This cerebral vasodilatation leads to a decrease in the left ventricular output. It is because of the increase in placental and the systemic vascular resistance. Thus, in the first stage of disease, the left ventricle flow increases so that the nutrients and the oxygen can be supplied despite the decrease in the placental output, placental transfer. After some time, there is a progressive worsening of the cardiac function, decreased symmetry from both right ventricle and left ventricle, and then the fetal venous Doppler takes over. The fetal venous studies have shown that in severe hypoxemia, there is a redistribution of the umbilical venous flow towards the ductus venosus at the expense of hepatic blood flow. There is a doubling of umbilical venous flow which contributes to the fetal cardiac output, and the hepatic blood flow is compromised. This impaired blood flow through the liver leads to the metabolic changes of acidosis. Thus, under the unfavorable conditions, the ductus venosus seems to ensure that blood flow directly flows to the fetal heart, and in extreme conditions, umbilical blood pass exclusively to the ductus venosus. So this increased placental resistance and the peripheral vasoconstriction, as seen in the fetal arterial redistribution, they cause the increase in right ventricular afterload, and thus the ventricle and the end diastolic pressure increases. This may lead to a highly pulsatile venous blood due to the transmission of atrial waves through this. The moment this phase reaches, then the inferior vena cava PI increases, followed by a high venous pressure induces the reduction in the velocity, followed by end diastolic venous pulsation, and at this stage the coronary blood flow slightly increases. That means an impending fetal death. So if the end diastolic flow in the umbilical artery decreases, there is an absent or reversal to the end stage. If it is in the early stage of pregnancy, the late stage may be slightly later, but in pre-eclampsia or fetal growth restriction, it may be earlier. So alterations in the venous flow velocity waveforms are in close temporal relationship to the intrauterine fetal jeopardy compared to the arterial blood flow, which may occur quite early during the course of impaired placental transfusion. And the degree of fetal acidemia can be estimated from the Doppler measurements of pulsatility in both arterial and the ductus venosus. One point to remember is umbilical artery PI changes may not occur until the 60% of placental villi are damaged. People did a pathophysiological studies when there is an absent end diastolic flow, when there is a positive end diastolic flow, and when there is a reversal end diastolic flow. In absent end diastolic flow, they have more fetal stem vessels with medial hyperplasia and liminal obliteration. The capillary loops in the placental terminal villi are decreased in number, and they are no longer and have fewer branches than the normal pregnancies. The reduced number and the maldevelopment of the peripheral villi result in the marked impairment of the oxygen transfer. While in positive end diastolic flow, there is a normal pattern of the stem artery development, increase in the capillary angiogenesis and development of the terminal villi, which are the signs of adaptation. In reversal, there is a poorly vascularized terminal villi. There is an increased risk of cerebral stromal hemorrhage. There is a hemorrhagic vasculitis. When people have delivered at absent end diastolic flow and at positive end diastolic flow, In absent end diastolic flow, there 0% babies were hypoxemic and 46% of the babies were acidemic. While in positive end diastolic flow, only 12% were hypoxemic and none were acidemic. So, in terms of fetal growth restricted pregnancies, the abnormal umbilical artery Doppler is a sign of an early sign of a fetal impairment. The abnormalities, they precede NST signs of fetal hypoxemia in almost 90% of cases except in abruption. And most important thing, the median time interval between the absent and diastolic flow and the occurrence of a late deceleration is about 12 days. So while this was theory, let me come to the practical aspect. Your doctor has done a Doppler, got a Doppler done. At 34 weeks, the Doppler says there is an increase in the umbilical artery resistance, but rest everything is normal. What do? I would wait for another few days, get Doppler done again after 3 days, 4 days. Increase in the umbilical artery PI means I still have about 10 to 12 days. Now believe me, keeping the uterus inside, a baby inside the uterus for 1 day is equivalent to keeping the baby in an ICU for 2 days. So if I can pull pregnancy for about another 10 days, that would give not only the maturity of the baby, yes, while the baby's weight may not increase by that much, but intrauterine environment may be a better, there is no better incubator in this world for the baby than the mother's uterus. The only thing is we have to make a balance whether this incubator inside the mother uterus becomes hostile for it to survive. So I always say umbilical artery blood flow decreases. The moment it stops, we have to take the baby out just before that. So these changes, again I'll summarize. Normally, the umbilical artery PI increases initially. Suppose that umbilical artery PI increases is at about 36 weeks. We know that in another 10 to 12 days, the deterioration would occur. So we can monitor the baby. Now, the important thing is, most of the people do not do the venous Doppler. As long as venous Doppler is normal, the baby is okay. Now, I was alluding to it in the earlier part of the video. If suppose the umbilical artery PI increases at 26 weeks, then what do? You can pull on the pregnancy for maximum 10 days, 12 days. In severe preeclampsia, severe fetal growth restriction patients. What I do in such cases, ecosprin 150 milligram, like I said, I start ecosprin 150 milligram in each and every of my patient. I do not know which patient is going to end up in increase in fetal growth restriction, increased chances of umbilical artery PI. So uterine artery, the low dose aspirin 150 milligram, it is supposedly increases the uterine artery blood flow, and that uterine artery blood flow supposedly increases the umbilical artery PI. Even if I can get 5 to 7 days more of intrauterine life of the fetus, that would make wonders, especially in a preterm patient of 28-30 weeks pregnancy. Second thing, I always mention in my anti-scan, if uterine artery PI is more, then I always start sildenafil 25 to 50 milligram per vaginal. Sildenafil, what it does is, it does the vasodilatation of the uterine arteries. The more the vasodilatation of the uterine arteries is, the more the blood supply to the uterus is, and that delays the chances of happening of increase in umbilical artery PI by about 7 to 10 days. Like I mentioned, those 7 to 10 days are very critical to me, especially at about 28, 30, 31 weeks mark. And lastly, if at 24 weeks of Doppler, if uterine artery PI is more or there is a persistence of uterine artery notch, I start low molecular weight heparin. Increase in uterine artery PI either at 12 weeks or at 24 weeks is mostly a surrogate marker of an antiphospholipid syndrome. In those cases, if patient is affording, I start low molecular weight heparin. Now from 24 weeks, if I start low molecular weight heparin till the time I get increase in umbilical artery PI, if I start heparin, there is a possibility that I may reach about 34-35 weeks of pregnancy. If I do not start heparin, I may have to terminate the pregnancy of 29-30 weeks. From 30 to 34 weeks, those 4 or 5 weeks, they make a world of difference. So in summary, I would like to tell that if umbilical artery Doppler is increased, there is nothing to worry. Not in that sense that there is no need to panic. You don't need to do an immediate delivery. Everything depends at what stage of pregnancy you are. If there is a 38 weeks pregnancy, if it is a precious pregnancy, there is a past history of a problematic pregnancy, past history of intrauterine fetal death, there is an IVF pregnancy, it is a diabetic pregnancy, then yes, we may deliver the baby. But if it is a first pregnancy, 36 weeks pregnancy, borderline maturity, then we may do an intensive surveillance. We may repeat the Doppler after 5 to 6 days. While the radiologist would say repeat Doppler after 7 days, what I would say, since Doppler is costly, I would say as a gynecologist, if there is an increase in umbilical artery Doppler PI at about 34-35 weeks, it is better to do a twice weekly non-stress test with an amniotic fluid. That's why I am doing a biophysical profile. If NST is normal and amniotic fluid is normal, I can prolong the pregnancy and I can repeat the Doppler after about a week. Like I said, if after umbilical artery resistance increases, after a few days there is a increase in the brain spinning effect. There is a brain spinning effect. That means the middle cerebral artery PI decreases. Cerebral vasodilation occurs. Do I need to terminate pregnancy at that point of time? Answer is no. Even middle cerebral artery PI decrease, that is brain spinning effect, does not mean that I have to terminate the pregnancy. Again, like I said, if this happens at 38 weeks, baby is fully mature, there is a good fetal weight, there are no other high risk factors, I can terminate the pregnancy. But if middle brain spinning effect occurs at 28-30 weeks, then I can still pull on for a couple of days more, as long as ductus venosus flow is normal, especially in case of extreme preterm patients. We should try to pull on the pregnancy. If the Doppler abnormality starts occurring at 36 weeks, give a shot of a betnizole and take the baby out after 36 to 48 hours. Many people say, if the Doppler changes are abnormal, can we go for a normal delivery? Because this is the most common questions we are asked. Sir, why not normal delivery? My friend, you need to understand the Doppler changes are abnormal. That means it is suggesting that, excuse me, the baby is getting less blood from uterus to placenta, from placenta to the baby in a non-stress state. That means without labor pain, if the blood flow is less. During the labor pain, when the uterine contraction occurs, the placenta and the umbilical cord contracts, and that also decreases the blood supply to the baby. If the Doppler is normal, then the baby may be able to survive those decreases in the blood flow for about 7, 8, 10 hours. But if the Doppler is abnormal, in a non-stress state, the blood supply is less, then in a stress of a labor, baby may not be able to withhold that stress, and those babies will require an increase in the NICU admission, and the chances of fetal morbidity, neonatal morbidity may be high. If we still delay the delivery, so at what point I should deliver? If at 36 weeks ductus venosus flow is normal, I will take the baby out, irrespective of the fetal weight. I won't wait for the ductus venosus pulsations to occur. I won't wait for the absence of a forward A wave. No, because by that time it would have become too late. Because I have had cases in past, patient says, sir, अभी तो 9वां महीना भी नहीं हुआ, अभी तो 7वां महीना चाह रहा है, baby को कैसे रखेंगे? It is better to take the baby out rather than let it die inside. If we still do late, I have seen the patients going in for necrotizing enterocolitis, and which patients would go for a necrotizing enterocolitis, that would be told to me by a decrease in the mesenteric arterial flow, that increase in the mesenteric artery PI. But do I need to wait? Waiting for a couple of days more in those kind of babies would not have any advantage as far as the neonatal outcome is concerned. On the contrary, there would be an increase in the NICU stay because of the necrotizing enterocolitis, increased need of the antibiotics. So in summary, I would like to tell Doppler is a very good measure of a fetal well-being. Doppler also tells me when to take the baby out without jeopardizing the outcome. However, if there is an increase in the resistance of umbilical artery, there is a fetal MCA, brain sparing effect, or there is ductus venosus changes, in those cases, normal delivery should not be attempted, because these babies, even if they deliver normally, they are more likely to end up in NICU because of birth asphyxia, because of meconium aspiration, and all those kind of things. Hope you like the video. Please subscribe to our channel. Please share the video. And if you have any questions related to the Doppler, please say in the comment box. Thank you. Namaskar. Bye-bye.